Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.in and drraghavamedicaldoubts.in. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatments and surgery details when necessary for the medical knowledge to general people and for reference to medicals. Today I am going to discuss about the benign prostatic enlargement, symptoms, treatment and the surgery selection. Anatomy. The prostatic gland lies in the fibromuscular stroma and their ducts open into the posterolateral grooves on either side of the volumonatum. The epithelium is columnar, commencing peripherally and passing centrally beneath the capsule lie the long branched prostate gland proper. Beneath this envelope and separated from it by an indefinite capsule lies another mass of secreting elements, submucosal glands, urethral gland. Benign enlargement of the prostate usually occurs between the 60 to 70 years of age. Etiology. There are two theories. Hormonal theory. As age advances, the testosterone diminishes and estrogen doesn't. Prostatic enlargement can be regarded as involuntary hyperplasia akin to fibroadenosis of the breast due to disturbance of the ratio between the circulating androgen and estrogen. Neoplastic theory. It is a fibromyoadenoma. If glandular tissue predominates, the middle lobe is maximally affected. Clinical features. Nocturnal micturition wakes up two or more times in the night for urination. Frequency. Frequency of urination during day and night. Urgency. The vesical sphincter becomes stretched. Little urine escapes into the prostatic urethra and causes intense desire to urinate. Dribbling. As the frequency increases, the dribbling occurs. Cystitis and renal insufficiency follows. Difficulty in micturition. The patient experiences delay in starting urination in spite of starting staining due to urethral stricture and fibrous prostate. Variable stream. It is usually weak, tending to stop and start and dribble towards the end of the micturition. Pain. It may be due to cystitis or retention. Hydronephrosis. When it commences, there may be dull pain in loin, feeling of weight in perineum, or fullness in the rectum. Acute retention. It is associated with the pain and compel the patient to seek relief. Retention with overflow. Complaints of continuous feeling and no pain. Hematuria. A drop of blood before or after urination or frank hematuria may be possible due to rupture of prostatic vein or erosion. Renal insufficiency may present with signs of renal insufficiency. Dry brown tongue, urine of low specific gravity. Investigations. Blood urea, blood count and Wassermann reaction. Excretory pyelography, cystourethoscopy. Management of retention. Acute retention is painful and needs to be rapid decompression. Chronic retention is painless and needs slow decompression. Catheterization. Indwelling catheterization is eligible. Shave the pubic, perineal, and scrotal regions, and local anesthesia is given, and Polish catheter is inserted. Urine collected for culture. Slow decompression. The collecting bottle kept 25 centimeters above the pubis and gradually bringing down 1 inch every 4 hours. Suprapubic puncture. If surgery is emergency option, the abdomen is punctured and keep a special catheter. Surgery indications: increasing difficulty in micturition, day and night frequency, delay in starting, and poor stream. Increasing symptoms in 3 years is an indication. Acute retention unrelieved by passing a catheter, emptying the bladder and immediately removing the catheter. Chronic retention, a residual urine of 6 ounces or more, raised blood urea, hydroureter or hydronephrosis demonstrated by urography. Complications: as stone infection, diverticulum formation in various combinations, hemorrhage, non-stop bleeding requires urgent surgery. Operative treatment: there are 4 routes of approach to the surgery, and vasectomy is done before surgery to prevent the infection of the epididymis. Transvesical prostatectomy procedure: the bladder is opened, prostate is enucleated by putting a finger into the urethra, pushing forwards towards the pubis to separate the lateral lobes, and then working the finger between the adenoma and the false capsule. In previous operation, bladder was left open and drained by suprapubic tube for urine and blood. Harris advocated control of the prostatic arteries by lateral stitches inserted with this boomerang needle, and torture of the raw areas by stitching the mucosa posteriorly of the internal barriers to the urethral mucosa and narrowing the cavity with stitches in front of the urethra, which was left in to drain the bladder. The bladder wall was completely closed and wound drained. Wilson Hay, stressing the importance of asepsis. Catheter is passed retrogradely, diathermy for bleeding control. Careful closure of the bladder enables the removal of the urethral catheter on the 4th day. Retropubic prostatectomy, Millin's prostatectomy, using a low curved transverse suprapubic incision which includes a rectus sheath. The recti are retracted, expose the bladder. The patient perineal prostatectomy, Trendelenburg position. Surgeon separates the bladder and prostate from the posterior aspect of the pubis. In the space thus obtained, the anterior capsule of the prostate is incised with the diathermy below the bladder neck. The prostate adenoma is exposed and enucleated with the finger, which is taken out of the posterior lip of the bladder neck to prevent secondary stricture. The exposure of the inside of the prostatic cavity is good, and control of hemorrhage is achieved with the diathermy and stitching before the closure of the capsule over a Progus catheter. inserted per rectum to drain the bladder. Perineal prostatectomy. Inverted V-shaped incision is made in front of the anus. The rectum is retracted backwards to expose the posterior aspect of prostate above the triangular ligament, and the adenoma enucleated. Side effect is incontinence. Pre-urethral per-urethral prostatectomy. Prostatic resection. Per-urethral prostatic resection indicated in case of obstruction is due to fibrous prostate, a median bore or carcinoma, and occasionally when a middle lobe is associated with a slight lateral lobe enlargement. It can be achieved with a McCarthy's resectoscope or a cold punch. Strips of the tissue are cut from the posterior lip of the bladder neck down to the virumnatum. Cutting accomplished with the high frequency diathermic current applied to the lobe. In case of Thompson punch, a tubular knife moves across a penetrum at the distal end of the sheath of direct vision cystoscope. After treatment, 4 ounces, that is 120 ml of sterile normal saline is left in the bladder for 1 hour to dilute the initial bleeding before continuous drainage starts. After 1 hour, the catheter is connected via a steroid tube to a bottle containing 4 ounces of formalin. Bladder washouts with a full aseptic technique. High urinary output is essential. If urine is infected, antibiotics used pre and post operatively. Early ambulation prevents the venous thrombosis and pulmonary embolism. Complications of surgery. Hemorrhage may continue. Clotting infection causing epididymitis, acute pyelonephritis, incontinence of urine, and extraperitoneal perforation of bladder. Late complication. Osteitis pubis is rare, unbearable, and after a long time may recover spontaneously. Post-operative structure of the prostatic bed is troublesome and requires repeated dilatation. More common is stricture of anterior urethra due to the passage of wide bore resectoscope or punch. That's all about the benign prostatic enlargement and the surgery. And in the next video, I will discuss about some other diseases. Thank you.